Welcome to Medicine Grand Rounds today. We're going to do something a little bit different that I think should be a lot of fun. And we wanted to present a debate. Many people have told me that there was a debate on PSA screening that was many years ago that remained a highlight in the Grand Rounds arena. And so we wanted to revive the debate. And just to sort of set the tone, our debate is intended to be somewhat lighthearted. So we will have two gladiators who I will introduce, and I've asked them each to take extreme sides on the question, which may or may not actually reflect their true feelings, and I will ask them at the end to let us know. But the discussion will be about procalcitonin, whether this is a clinical game changer to help clinical decision making, or not so fast. And our two protagonists today presenting the pro side, and I will read you their bios as they were sent to me. On the pro side is Dr. Joel Zivot, who's an associate professor of anesthesiology and surgery here at Emory. He's a full-time clinical intensivist and has been in practice for 27 years. Dr. Zivot has seen the evolution of sepsis treatment, including the rise and fall of the HA1A monoclonal antibodies, supernormal oxygen delivery, gastric intramucosal pH, and he remembers remarkably when imipenem killed everything. Zivot remembers when all central lines were changed every 3 days to reduce the chance of blind sepsis, and the debate about sucralfate versus ranitidine and the concern over gram-negative gastric overgrowth. He even knows the guy that came up with the checklist manifesto to reduce line sepsis. Joel has practiced through various pandemics, including TB, HIV, H1N1, SARS, MERS, and now COVID-19. He has taught biology to Tibetan monastics and told the Dalai Lama a joke. And in fact, the Dalai Lama reportedly laughed, although I'm taking that secondhand. Joel is a senior fellow in the Emory Center for Bioethics, has been to death row in 7 states as he works against the medicalization of punishment with a specific focus against the use of lethal injection for capital punishment. So Joel, thank you very much for joining us. Our second presenter will be Dr. Gavin Harris. He will take the con side in this debate about procalcitonin. He's an assistant professor here at Emory, holding dual appointments in both the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine, as well as in the Division of Infectious Disease. He practices in several intensive care units across the Emory system, consults on inpatient infectious disease services at EUH, and is a staff physician for the Serious Communicable Disease Unit. He's the medical director for the Emory University Serious Communicable Diseases Program Project ECHO, which is a subject matter expert for the National Emerging Special Pathogens Training and Education Center. And he is an alumni fellow in biosecurity at the Hopkins Center for Health Security. But before he was a physician, he was a professional musician, though it's been some time since he's had a chance to play, much less perform. Good luck catching Dr. Harris in anything more formal than scrubs, as he's most comfortable in board shorts, the result of a passion for surfing around the world that borders on obsession. So here are our two combatants. And the order of the day will be that Dr. Zivot will start and present the pro argument. Dr. Harris will present the con argument. Dr. Zivot will have an opportunity for rebuttal that's brief, and the same for Dr. Harris. And then we will be open for questions. Joel, why don't you go ahead and share your slides, and I will let you take it from here.
Okay. Let's see. You tell me if can you see that now?
That looks perfect.
Great. Well, thank you for having me. And Gavin, although you are my friend, I apologize because I'm going to kick your butt today. We're going to talk about Procal, and I am the pro side. I think, of course, it's named aptly Procal, meaning pro. The name of my talk is the biomarker in place of magic. And let me start by quoting Arthur C. Clarke, who famously said, "Any sufficiently advanced technology is indistinguishable from magic." And I think it's important to talk about magic because I'm really not interested in magic when it comes to medicine. I think that medicine is populated by people with strong beliefs. And particularly, and I say this with all due respect, with my infectious disease colleagues. So a typical infectious disease consult might be, I've got a patient that I'm concerned about that may have sepsis, and I get a consult and the infectious disease doc comes by and says, I don't think so. Or they may also say, I think so. So my question is, which one is it, and how do you decide? So I think that Procal, hopefully here today, will help dispel the magic. So this is the case that I'm going to ask you to keep in your mind. This is not an actual patient, but but a patient that I'm sure that we've all seen before, or something akin to it anyway. This is a 56-year-old man who's got a past medical history of diabetes, 2, hyperlipidemia, hypertension. He's got a body mass index of 35, so he's a generous fellow. And he's had several days of feeling unwell, including progressive dyspnea and fever. So he comes to the hospital and he's seen in the emergency department. Lo and behold, he's found to have COVID, and he's transported up to the ICU with severe respiratory distress. He's on Airvo, 90%, and 60 liters of flow. The chest X-ray shows diffuse bilateral infiltrates. His white count is 14.9, and the question is, should I check a procalcitonin in this patient? So what is procalcitonin? Procalcitonin is a protein. It consists of 116 amino acids and is the peptide precursor of calcitonin. Now, calcitonin is initially biosynthesized as procalcitonin, which under normal conditions is found in low levels in the circulation. There's very little bit of it that circulates, and under normal circumstances, it's mostly undetectable. Back in 1993, it was first noticed that in patients that had bacterial infections, procalcitonin levels were actually found to be quite high. And correspondingly, patients with mild or local bacterial infections or viral infections, which is important here, were found to have low procalcitonin levels. Now, what is sepsis? I'm sure sepsis is something familiar to this audience, of course. Sepsis is a life-threatening organ dysfunction due to a dysregulated host response to infection. Now, currently with sepsis, there is no gold standard biomarker for infection. If only we had the troponin of infection, everyone would be happier. So a sepsis biomarker is needed. And of course, a biomarker needs to do the following. It needs to identify when present infection. It needs to predict the course of illness. It needs to guide treatment. It needs to improve outcome. And these are all of the things that we would like it to do. Now, there are many studies on procalcitonin, and I just want to bring to attention one of them right now, which is highlighted in red here. This is a study by Rodriguez. This was a multi-center trial. It was a prospective trial. My dog is barking. And it looked at 972 patients. And what it found, it was interesting to me because it looked at a patient population that was suffering from H1N1. And it found that it excluded bacterial co-infection in those patients. Here's that study. Again, it's from the journal Infections 2016. And it starts with the statement, the diagnostic ability of procalcitonin to indicate infection was also demonstrated in observational studies of respiratory disease. And that, I think, was the justification for this study. And in a large prospective multi-center ICU study in patients with H1N1 influenza, procalcitonin had a 94% negative predictive value for excluding bacterial co-infection and outperformed CRP. By the way, CRP, another favorite biomarker of mine as well. Here's another paper, procalcitonin for patient stratification and identification of bacterial co-infection in COVID-19. This is a recent paper, and what they found was that the lack of procalcitonin rise in viral infections may be due to virus-stimulated production of interferon gamma by macrophages, Interferon gamma, as people may know, is turning out to be a very important biomarker and also very important in the regulation of sepsis. Oh, you know what? Hold on one second. Sorry. Apologies, had to just put my dog out. So here's another paper from recently from 2021 that looked at procalcitonin from a different perspective, which was a quality improvement project to look at the role of procalcitonin in antibiotic stewardship. So in this paper, antibiotic stewardship during the COVID-19 pandemic, it's an important part of comprehensive strategy to improve patient outcomes, reduce long-term adverse effects secondary to rising antibiotic resistance. The results indicated that antibiotics were either never started or were stopped within 48 hours in 72% of COVID-confirmed cases with procalcitonin that was low, and that procalcitonin testing, when used in combination with thorough clinical assessment, is a safe, simple, and sustainable way of reducing antibiotic use in COVID-19. Here is also another recent paper that looked at baseline procalcitonin as a predictor of bacterial infection and clinical outcomes in COVID-19. This is a case control study. In this particular study, there were 324 patients that had their charts reviewed and were grouped by clinical and microbiologic outcomes by day 28. And at baseline, procalcitonin levels were significantly higher for patients who were treated for true bacteremia and bacterial pneumonia compared with the non-bacterial infection group, and that baseline procalcitonin positively correlated with the NIAID ordinal scale and survival over time. When compared to other inflammatory biomarkers, procalcitonin showed superiority in predicting bacteremia. So, my point, well, do I check the procal in my COVID-19 patient? I think that the answer here is yes. And these are the reasons. I think that procalcitonin can distinguish severe bacterial infections from mild bacterial infections, and that elevated procalcitonin levels suggest severe COVID-19 infections or bacterial co-infections and is therefore a prognostic indicator. And when I say this, I mean, although procalcitonin is not a therapeutic endpoint, at least it can help us figure out whether someone is sick or not. And that procalcitonin can assist with antibiotic stewardship by eliminating or shortening antibiotic usage in COVID-19. And I will, let's see, I will leave you with this last slide, that if you torture your data long enough, it will confess to anything to you. So keep that in mind, because the problem here, of course, is that when you have to believe information that you have, and if your belief is the opposite, then evidence be damned. Okay, that is the end of my talk. Let me see how I can share now. Here we go, should stop sharing.
Right.
Oh, that's it. Okay, thanks.
Thank you for that pro side. I think your dog was trying to interrupt it. Does that mean your dog is actually anti-procalcitonin?
My dog, you know, my dog. Anyway, yes. Okay.
All right, Gavin apologizes that his camera isn't working, but Dr. Harris, you want to present the opposite viewpoint?
Absolutely. Can you all see my slide?
We sure can.
Okay, great. Well, first of all, thanks, Joel, for those excellent points. Apologies again for the technical difficulties. I'm just going to provide some food for thought here and some words of caution before we dash headlong into the procalcitonin camp. So I want to begin with a little background too. Joel mentioned this briefly. It's an amino acid precursor of calcitonin. It's produced by multiple different cells of the body. And in theory, this should really work quite well, right? Procalcitonin rises about 3 to 6 hours after an infectious challenge, peaks about 6 to 12 hours, and seems to show remarkable ability to predict and almost even indicate infection that's much better than other biomarkers that we have. So in theory, alone or in combination, this should serve as a promising tool for understanding the prediction, cause, and progression. Okay, can you guys see what's going on here? Okay.
Something's great, yeah.
There we go. Okay, but before we do that though, I want to just show this slide because our biomarkers are not perfect, as we all know. And down here at the bottom is procalcitonin. As you can see, it's specific for infection, but it's not very sensitive, and it's released during infection with multiple different things. So although we like to talk about co-infections with bacteremias, I don't want to lose sight of the fact that there have been evidence to suggest that it's elevated in fungal infections, parasites such as malaria. There has been good data to show that it does differentiate viral from bacterial meningitis, but there are a lot of caveats too, because non-bacterial cytokine activation can increase procalcitonin at baseline. And if you look at these, areas in which it is elevated, these are all areas of patients that we have in the hospital, right? So patients with renal failure can have elevated procalcitonin, they don't excrete it properly. Newborns up to 72 hours, procalcitonin is not reliable. Treatment with agents that stimulate cytokine production, so things like alemtuzumab, which we use in transplant patients, granulocyte transfusions can increase procal. Prolonged severe cardiogenic shock, organ perfusion abnormalities can increase procalcitonin, and even paraneoplastic syndromes. So we really have to be aware of confounders in which procalcitonin can be present. If we don't have baselines, this can be very problematic. Joe showed you a big slide of a lot of different studies, that have looked at procalcitonin, but I just want to make a point. This is a smaller slide, a little bit older studies, but these are classic studies from Europe, and newer studies have really shown similar things. I want to direct your attention to the results column, because if you'll notice that while we had significantly decreased use of antibiotics in these studies, and even in the ones that Joel showed you, if you look at, there's been no differences to be shown in adverse outcomes or mortality, which I think is an outcome we really have to be aware of. Moreover, some of these studies, especially ones, the one that was published in 2009, if you look, this required providers to enter every procalcitonin level in a website. It also required that when they were veering off of procalcitonin guided therapy, they required to call the study center, which is really not feasible in the United States. So we really have to stick with evidence here. Procalcitonin has been shown in evidence of lower respiratory tract infections to look at these cutoffs for evidence of when we should employ the use of antibiotics. Down here, if you'll note too, these studies have all combined procalcitonin with additional information, with additional scales such as the pneumonia severity index, also the GOLD scale and the CURB 65 score. So nothing in isolation, which I just want to make a note of. For another study that was done, this is a study looking at sepsis and procalcitonin levels. You'll notice those levels are different from lower respiratory tract infections. And the sepsis 3 guidelines did not even include procalcitonin. And the authors in their article, which led to these guidelines that we use, have looked at that they came up with these because there's a compromise between a low threshold and a high threshold, as it can have unnecessary consequences for the patient. So things to keep in mind here. In fact, the FDA, when they cleared procalcitonin tests for sepsis, it was based on a meta-analysis conducted by the pharmaceutical company that had a lack of US clinical trial sites. So just keep that in mind. This is a landmark study done in 2018 at the University of Pittsburgh, in which they tried to ask 2 important questions. One, can procalcitonin reduce antibiotic use, and is procalcitonin guided care safe? What they looked at was 14 tertiary care US hospital sites. The inclusion criteria you can see there. Interestingly, they wanted physicians willing to consider procalcitonin in decision making and about before. And what did they do? Well, they literally said, we will provide you with procalcitonin levels and the test itself, and we will give you this algorithm to help you determine as to what to do when the result comes back. So physicians were literally handed this on a platter, so to speak. And what do they look at? So the antibiotic days by day 30, they found there was no significant differences in any subgroups. For antibiotic exposure, there was no significant differences. For acute bronchitis, which was actually a subgroup comparison, they actually did find a difference in antibiotic exposure. But so what really happened? Well, it showed that procalcitonin didn't really improve outcomes that they were looking at. As you can see, when patients have low procalcitonin, the results were largely, not different, not surprising. These are patients you wouldn't normally prescribe antibiotics to on the left side of the screen. On the right side of the screen, these are patients extremely sick. They're going to have high procalcitonin levels. They're going to get antibiotics. It's the two columns in the middle that we seem to have significantly different, or we have problems with. And as you can see here, discharged to day 30 again, there was no significant difference between antibiotic usage. This study, while it is from 2018, did show that there were some significant physician psychology problems. 39% of responders felt that the patient had a bacterial infection present, even though a procalcitonin level was low. Some felt that the patient had COPD exacerbation that required antibiotics, because there's evidence to suggest that COPD exacerbations need antibiotics, so that's a debatable point outside the scope of this talk. And there was found to be the antibiotics were given before even the procalcitonin results were available. But the authors didn't stop there. They wanted to come up with a way to simulate 100% adherence to a procalcitonin guideline analysis or guideline-based therapy. So instead of performing a non-inferiority randomized trial, they did this per guideline analysis with an instrumental variable approach. And what they found is that there would be a difference in antibiotic prescribing with less than negative 0.1 day. This is not really going to change antibiotic usage. It's too small of a data point. So what am I trying to get at here? Well, there's a difference between how tests perform in controlled settings versus how they perform in clinical settings, okay? Not every place also has a procalcitonin ability or the ability to run this test. Not every place has the ability for someone to read the test. So the evidence really hasn't borne this out quite just yet. So interpretation in the clinical setting is important. How does it fit with current practice? Well, again, in green, you can see what we want to achieve, as Joe also mentioned here. I'm trying to get at the fact that we can't solely rely on procalcitonin. There have been studies that looked at procalcitonin in conjunction with respiratory viral panel testings or respiratory pathogen panel testings. Again, they've shown that this infrequently alters management. Here as well, if we combine procalcitonin with RVP testing, as you can see, no difference in overall antibiotic usage found. Perhaps a combination of biomarkers will ultimately become a functional clinical application, but I'm not sure we're there yet. We also have issues with viral carriage versus infection, right? 60% of patients who are admitted to the hospital with a lower respiratory tract infection, we may never discover a pathogen. The question always comes to, if we do we have a treatment available for that? So the expectation, a single laboratory test, will dramatically affect clinical care, I think at this point, may be a little bit unrealistic. But there are some key principles that may have some use for procalcitonin. We have to make sure we interpret in the clinical context of a patient. So serial measurements would be super important. We can't just take high procalcitonin and act on that. Other inflammatory events, like I mentioned, may cause alterations. We also have to consider the dynamics of the disease. Sometimes people who have elevated procalcitonins, it could take a long time to recover. It has a long half-life. Just like in pneumonia, radiographic findings can take some time to normalize. Again, we have to be careful of those conditions that affect procalcitonin. I also think we have a duty to deliver quality care and quality cures. So we have to take into account the medical costs. Procalcitonin costs about $30. CRP costs about $12 to $16, depending on the lab that runs it. We also need to make sure that we have decreased cost savings through decreased complications of antibiotic usage and drug toxicity. So this is not a super cheap test, okay? I mean, someone who comes in with a temperature of 39 degrees Celsius, hypotensive, white blood cells 30,000, we already know they're sick. They're probably going to get antibiotics. They may get pressors and go into the ICU. Procalcitonin at this point lacks sufficient precision as a standalone method to diagnose or rule out infection. And as an ID physician, we often get consults to just examine patients. We have so many tools these days to examine a patient. On the side of this slide, you can see all the different ways we can use ultrasound. I can't emphasize enough, a plan to send a procalcitonin as part of a fever workup while neglecting thinking and other validated tools, to me, is not an appropriate workup. And it cannot be denied that procalcitonin may play a role in antibiotic discontinuation. I mean, we all play a role in stewardship and in preventing the next pandemic from antimicrobial resistance. Researchers have looked at procalcitonin with the goal of decreasing antibiotics and duration in the ICU, and these conclusions have been consistent in findings, but heterogeneous in recommendations, as you can see here. We can reduce antibiotics without worsening mortality rates. It may do so to an appreciable extent, but the mortality all-cause remains unchanged. Here in 2017, we had a meta-analysis that did show a short-term mortality and the duration of antibiotic use or exposure was improved. But again, as you can see, this is for antibiotic discontinuation only, not for initiation, not for both, for discontinuation only. We need to be careful how we apply evidence. So ultimately, too, for me, before we consider Procal as the paragon of biomarkers, we need to think about stopping antibiotics. This, I think, is one of the root problems. We all have a duty to prevent this pandemic, okay? In terms of COVID, like Joel brought up, there are these studies from China that have reported, procalcitonin levels that have been elevated. 2 studies, in fact, correlated a level with severity of disease or risk of death. But we have to be careful how we interpret this. Not all patients in these studies had procalcitonin levels obtained. Disease severity varied widely, and it's unclear actually how many bacterial co-infections occurred. In COVID patients, for me, there are 3 possibilities when you have an elevated procalcitonin. One, it could be a bacterial co-infection, could be a marker of severe ARDS, and it could be a marker of immune dysregulation that increases production of those cytokines we talked about earlier that are non-infectious. So I leave you with this, the jury is still out.
Thank you, Dr. Harris. Dr. Zivit, do you have a rebuttal to that argument against your stance?
Well, let me say, first of all, that obviously, because Gavin is younger than me, he uses PowerPoint better than I do. So I'm a PowerPoint minimalist, but next time I'll try to see if I can do some more animation in my slides. Look, I think that, Gavin raises fair points. I think that procalcitonin is not the end of the investigation required to clinch a diagnosis of bacterial infection. I think it's an adjunct. I think it adds to the armamentarium of the movement towards certainty. And I guess I still use certainty in quotations. I think that procalcitonin is valuable when it's trended, like many values. I think that the problem, I think, of trying to determine the state of patients and the direction of patients is whether they're getting worse or better, is that we don't have enough data. It's not that we have too much, it's that we really need to take data much more often than we actually do. But of course, that's cost prohibitive, and the mathematics of that get complicated for most of us. But it's these small changes over time that I think are very valuable. In my clinical experience, I found procalcitonin in the time of COVID to be helpful, to be reassuring. And when I have a patient like that, patient that walked into the emergency department like I described, if that patient's procalcitonin was undetectable, I'd feel pretty comfortable not starting that patient on antibiotics and waiting and seeing. Now, that's not the same thing as me saying I'm going to phone it in from there on in. I think I need to continuously evaluate that patient, but that's a pretty valuable and important piece of information. And I remember, I'm sure as Gavin does and others, is that when COVID first came and we saw these patients, we didn't really know what we were dealing with, and all of them got antibiotics too. So the fact that we were able to comfortably start, to stop giving antibiotics to everybody automatically, that was, I think, a big breakthrough. And I think that procalcitonin was very much involved in that decision.
Gavin, do you have more comments?
I do. Joel raises great points. And I will say I've taken over patients from him in which he's trended procalcitonin for days, if not weeks at times. And sometimes I have no idea what I'm going to do with those values, because at the time that I pick up some of these patients, they're in florid renal failure or cardiogenic shock, or there's concerns that perhaps they may have a fungal infection or whatnot too. So I think there are these confounders that we can't really do away with. And a lot of times, in the intensive care units, I've seen, when patients spike a fever, someone sends a procalcitonin level. The patient has had, 4 or 5 different lines that have been placed, or they've been in renal failure for some time, or they come with, having multi-organ failure at the outset, and we don't have a baseline for procalcitonin. And it's very difficult to interpret in those times. And Joel is absolutely right. we need to stick with the evidence. We do need better data, but we just don't see that happening, I think, in the real world. In the laboratory, procalcitonin, as I think both of us have shown, has definitely shown promise, but the real world experiences just have not yet played out. I think there are cheaper tests, are cheaper ways of thinking that can help us along with treating these patients. I mean, our physical exam skills, I think in the modern era and in the era of COVID, have kind of fallen by the wayside as patients have become isolated, as nursing care has changed. And so we rely less and less on physical examination and the skills that we learned in medical school, and we rely more on kind of word of mouth or secondhand knowledge. And I think that's a real problem when we start to replace that clinical decision making with a non-precise biomarker.
All right. Well, I think those are some great words. Audience, please feel free to either raise your hand or put questions in the chat. I think for both of you, one question, I think that the point about physician psychology is really an important one, because I guess my question always is, do people, if you are a procalcitonin believer, do you really stop antibiotics if the procalcitonin is negative? Or if you still have significant concerns that a patient is infected, are you likely to continue antibiotics? And do you use the procalcitonin only to bolster a decision that you were comfortable making in the first place, which is to stop antibiotics?
Wendy, I wanted to comment on that because I made a note to myself about that. Gavin and I have had this kind of conversation before, and there's the quote. It's something like, "I'll see it when I believe it." And I think, the problem is that that belief anyway is kind of evidence-free. And I think that belief is very powerful. And once you think that something has happened, that it's surprising how much evidence can be put in front of you to the contrary, and you will not change your mind. I mean, sadly, I think we know this very much in our current moment with people's attitudes about, vaccination safety, for example, that once you think something is in play, it doesn't matter, the evidence be damned. And so I think if you think that you've got something, if you think your patient is, has a bacterial infection, and you've got some evidence, that supports that, then it's very hard if something comes forward and says to the contrary, and vice versa. So I just think that that the problem here is the way that we reason as well. And of course, a scientific inquiry is basically about correlation anyway, and not causation. So the research, the literature doesn't necessarily help. It just says that these things go together, but whether or not A causes B, well, that's a very difficult kind of, of study to design.
Yeah, I'll just add and interject there. That is one point that Joel and I can probably agree on. I mean, one of my colleagues, Brad Spellberg from USC, just said this week that it's up to all of us to teach ourselves to recognize our own anchor bias, to ignore traditional anchoring teaching that's not based on data, and actually treat patients based on high quality data that we have available in front of us. And that's been done. I don't think yet that we have that data from procalcitonin, but Joel raises an excellent point that sometimes, it's up to we use facts to suit our opinions rather than base our experience on evidence.
Dr. Alter, do you want to ask your question?
Yeah, David Alter. I'm Director of Chemistry, Clinical Chemistry here for the Department of Pathology. And my comments are not related specifically to the assay or its use here at Emory, but I've been in practice for 20 plus years now as a pathologist in chemistry. And my experience has been that there is no right or wrong answer, because I've seen procalcitonin as a good assay in search of a use. I remember when it was first implemented as a sepsis marker, and then sort of has evolved or been tried to have found a use as antibiotic stewardship. So I think the jury is still out. I want to share one personal concern that I've always had with the assay, and that's how it's reported. And that's, in healthy people, we don't expect it a level greater than 0.1 micrograms per liter per liter, but we then see there are levels between the absolute normal and then when it starts to show up as a disease marker, and then another gradation before it starts to show up as a sepsis marker or worthwhile as an antibiotic steward marker. So I've always had a little discomfort, and this may not relate to Emory, reporting out results as, quote, normal when they're not technically normal. And on the other hand, I know clinicians, my colleagues in clinical medicine, have had concerns reporting out abnormal results when they're elevated but still not worthy of sepsis or even antibiotic stewardship. So it's a great debate that needs to be had and needs to be continued for sure, because in 10 years we might find procalcitonin going the same way as high sensitive CRP. Thank you for your time.
Oh, thank you. Some great comments from the laboratory perspective, which is incredibly valuable. We have a couple of questions in the chat, and the first one I may expand on a little bit. What are your thoughts on using procalcitonin for patients who have aspiration pneumonitis, and can it potentially help with minimizing antibiotic use? I thought maybe you could expand that and even talk about sort of indications where it might be really useful. You both talked a lot about COVID-19, and for me, that's an interesting example as well, because it can be difficult to decide if this infiltrate is only COVID-19 or if you're worried about something else, which is a different scenario, or aspiration pneumonia, which is a different scenario than someone coming in with, a different kind of undifferentiated clinical presentation and using that to choose whether to decide if somebody's infected or not. So I was curious if you could both comment on that.
I guess I'll start. I think that, with aspiration pneumonia, of course, it depends a bit on when you see the patient. So if someone aspirates in front of your eyes, then it's, I think, that at that moment that may not be the time to determine whether or not you think you've got a bacterial infection or not. I mean, I think we think of aspiration as, classically, I guess, as a chemical pneumonitis. And so I might just wait anyway and see. It just would depend. I think that the immediate use of procalcitonin immediately after aspiration, I don't know that I would reach for that. I would wait and see. And I think over time, and probably, my pattern generally is probably not to treat these patients with antibiotics right away. If the clinical condition changes and I begin to suspect bacteria, then I suppose at that point maybe I would consider adding procalcitonin as well.
Yeah, I kind of tend to agree with Joel. I mean, we have criteria already and features of aspiration pneumonitis versus pneumonia. Of course, they're often difficult to elucidate, and aspiration pneumonitis can range from no symptoms or severe symptoms that can even resemble, or patients can have tachypnea, bronchospasm that requires intubation even. And this can be anywhere from 2 to 5 hours after aspiration. And of course, it may take a bit of time for bacterial pathogens to invade after someone aspirates, whether that's oropharyngeal material or gastric contents. So I tend to agree with Joel. I usually refrain anyways from starting antibiotics in these patients, and it may be a little bit challenging and too difficult for procalcitonin to have a role here. But again, I don't think we have evidence in this. It's certainly an interesting proposition.
Wendy, could I just comment briefly on David's comment about the laboratory value of Procal? One of the things that I struggle with is, what to make of the number that's, say, less than 1 or less than 0.5, these very low numbers, that are near, quote, normal, and what to make of those numbers. When I've seen procalcitonin in certain patients where, they're clearly very sick and turn out to have bacterial infection, and the procalcitonin is a double digit, that's very reassuring. But it's the very low number that I think is hard to make, what to make of it. And also, I think that this is maybe a criticism or a comment about the electronic medical record, and I call it, the tyranny of the red value. So someone has decided that certain kinds of values should be changed in color, because they now fall outside of a certain range, and that's supposed to warn you that something bad is happening. It's a little bit like when the radiologist puts a little arrow on the chest X-ray to point where the abnormality is. Like, I appreciate it, thanks. So this red value, and to say whether something is abnormal or not already is, that's, I guess, someone's opinion.
I wasn't involved with the implementation here, but I do know that there was a lot of clinical input on where the levels were set. And, but I do share your concerns. In a previous employment, I got a lot of pushback from infectious disease and so forth, because I was uncomfortable calling less than X, quote, normal, when patients, individuals, sick people were not clearly normal. As for why someone might be really, really sick, if you will, and show a negative number or a normal number, I think those bear some investigation. It could be that the value was so high that it's gone past the capacity of the instrument.
Thank you. Question from UHM. Is there any role for incorporating procalcitonin into composite risk scores, maybe even automatically calculated in the EHR for either severe disease prognosis or presence of bacterial infection?
So I can go on this briefly. So there have been studies done to have looked at composite scores with procalcitonin, with respiratory viral panel testing. I do think there may be a role for this. Again, I think this goes back to Joel's point that more good data is very important, especially when we have complicated patients. I don't think we have the evidence to support that even if those scores are incorporated, that physicians and providers will act on them appropriately. Joel?
I mean, I think that to be able to predict, which patient will do poorly is, of course, useful. I think that, I tried to make the point earlier about the difference between a prognostic indicator and a therapeutic endpoint. Like, it's fine, what we want, of course, is the latter. I mean, the former is helpful to begin with, but if all we have is more prognostic indicators and we can't do anything with it, well, it doesn't feel very satisfying. And the distinction between a prognostic indicator and a therapeutic endpoint is hard to know. Like, I was in my my description of myself, I remember supernormal oxygen delivery and septic shock, where we thought that we could turn the non-survivors into survivors by putting them on inotropes, because we saw that people who had septic shock, when they raised their cardiac output, that was a survivor group, and the people that lowered their cardiac output, that was the non-survivor group. That turned out to have only been a prognostic indicator, not a therapeutic endpoint. So I guess the real question will be, well, is there such a thing? Is there something that can be directly done to procalcitonin? Can it be, say, lowered in some way? That would actually have some beneficial effect, where the target now is procalcitonin. That's just what I was thinking about.
All right, another question. Application of a test with its sensitivity and specificity always requires a pretest probability. Perhaps in this debate, does your patient have a bacterial infection that you're trying to determine? Can you comment on test characteristics to diagnose a bacterial infection from the literature? Sensitivity, specificity, etc.
Well, I mean, I think that you're talking about Bayes' theorem, of course. So pretest probability is always, very important. So it starts out, and this is, I guess, where kind of the problem is that if you think that you've got a patient that has the, signs and symptoms of a severe infection, and then you begin to test for it and you find that it's there, then it's very likely you've got true positives. So I think that, I think this is more of a qualitative kind of question, that it's just more, that once you've got a patient that exhibits the, the clinical findings, then, then when you begin to test for it and those tests point in that same direction, then I think it's more a function that it can be believed and relied upon. And the opposite is true. And then a patient that really has no signs of infection whatsoever, that if you begin to find, say, an elevated procalcitonin in someone who was really well, then I think it's likely to be, a false positive. And I guess that's the way I would approach that.
All right, and I think I'll sort of start to wrap things up. Gavin, could you tell me, who do you send a procalcitonin on? Do you ever use the test?
That's a great question. I will say there have been times when I have sent procalcitonin recently on COVID patients in the ICU in whom I'm concerned that I may need to start higher dose steroids on, perhaps. And the reason I send it is because I am concerned that I wanted to get all the data that I can to see if there's a chance that they may have some co-infection, that if I further immunosuppress these patients, that may unmask an infection and cause rapid demise. And these are patients in whom, may be steroid responsive, so they may have evidence still of ground glass opacifications on their CT scans or evidence of organizing pneumonia. And so in these select patients, I will send a procalcitonin to kind of get all the data that I possibly can.
And Joel, who do you not send a procalcitonin on? Like,
I don't send it on people who are well. I don't send it on people who are, I feel like I've got the diagnosis. If someone's, if I'm trying again, like, I guess, to confess, where I've been thinking about procalcitonin is not so much where, the evidence is strongest, which is that it may be when the procalcitonin is fallen, it's now safe to stop antibiotics. I use it sometimes to see whether I think that infection is coming. And so I'll do it in patients, say that, those COVID patients, where I'll check CRP and procal. And if the procal is low and the CRP is high, then those patients may get steroids from me. The interesting thing about procalcitonin and steroids, of course, is that steroids don't seem to have an effect on procalcitonin levels where CRP does. So I can actually use kind of the, to answer the question whether I think that I'm gaining some benefit by giving high dose steroids to these COVID patients. And then as the CRP falls and the procal stays low, I think I'm getting away with it. If the procal starts to rise, I think maybe I'm not getting away with it. And that's kind of the way I approach it.
And lastly, is anybody, so here we have the two of you, and there's clear variability in how you order procalcitonin. Is anybody sort of studying those of you guys who order versus not order? Because that's a natural experiment to see if there's a difference in whatever outcome you choose, antibiotic use, mortality, et cetera.
I think that, so I work in 5E ICU, and I feel like I'm the only person there that orders Procal. I think all my colleagues think I'm nuts and for ordering it. Although when I do go on, the APPs who I work with very graciously start ordering in all the patients during my week. So I guess it's nice when people can read your medical mind.
It's funny. No one is saying, I think it's a reasonable thing to look at, honestly. I will say when I come on service sometimes, all the APPs, maybe they're following Joel and whatnot, and they've all ordered procalcitonins. And then so I ask them, all right, what are we going to do with this information? And a lot of them kind of just stare at me blankly. Similarly, I think we have issues in how we interpret urinalyses. But I think the overall point underlying all of this, and Joel has certainly brought this up, is with antibiotic usage, less is more, right? And so the ultimate goal is to see if we can decrease antibiotic usage. By that token, we can decrease exposure, we can decrease lengths of stay, drug toxicities, and complications. And so I think we really need to focus on getting people to follow validated evidence-based guidance on reducing antibiotic exposure, and shorter is better. There's this whole movement in infectious diseases that is really gaining steam and strength before we rely on a single biomarker, to supplement our clinical, or to not supplement, but to replace our clinical judgment.
I think I'm going to let that be the last comment. Thank you guys so much for engaging in this. This has been really fun and really educational. And I think it has expanded and rounded out our views on this a lot. And I've taken a lot from it. For everyone else, again, let me know if you enjoyed the debate format. Feel free to send me an email if you have ideas for pro-con debates. And we'll see you next week.
Thank you.
Thank
Thank you
you.
very much.